Recording. Again, this is Dr. Garais, and this is Med260 7DAX Exams and Specialty Procedures. If you so a couple of public service announcements out of the way. If you haven't registered, please do so, and try to get it done by today, because a lot of people are taking off for the July 4th weekend, and things won't get processed until at least Monday. So if you can get stuff done today, especially if you have any student account holds or any issues with registering. And how would you know that? If you did, you look at your email, your official student email, and you go in here in your self-service portal. It tells everything about your midterm grades, everything that you need to know. What is the top? And also, if you haven't also sent me an email regarding confirmation of when you're coming in for the laboratories, remember, we need confirmation so that, especially around the weeks that you guys have your lab, and the laboratory schedule is located in the announcements, there's going to be a decent amount of people on campus, nursing, Falls Church campus, and culinary. We're trying to coordinate it so that there is a least amount of people. But if you just show up to the labs without confirming that you're coming, you could be potentially turned away, and I don't want you to make the trip out to the campus for nothing. So please email me, confirm the dates. If you can't come to those dates, let's talk about alternative dates. If you're worried about exposure, I also have weekend and evening one-on-one laboratories during times where there's nobody on campus. So that could be an alternative for you. And then last but not least, an alternative assignment. But for this class, this is a laboratory class. So please, I'll find you another alternative assignment. But there's a lot of neat skill sets here that you really need to practice. And one of the things that we're going to talk about today is minor surgery. And we're just going to go over the differences of the different kinds of scrubs and scrub procedures, because even if you're not doing like real surgery, you may be asked to scrub into a minor surgical procedure. And many of the minor surgical preparations mimic the larger things that you have to do in the operating room, but not to the same scale. And also, you should know what happens in the operating room. You may end up helping out there as well. Discussion 7, quiz 7. Again, email me your answers for this quiz 7 by next week. And what is the importance of pre-admission testing? That's what PAT is. So look up in a typical hospital, what are the rules and regulations? And remember, my lecture always talks about how every rule, every regulation in the hospital, no matter how esoteric, there's a reason for it. So that's what this discussion is about. Get me the rules and regulations, of course, cite it via APA format, and then discuss why is it important. Like, we now know that asepsis, or the surgical scrub, part of the surgical scrub procedure, is really important, especially in surgery, because in surgery, I'm breaking your skin. I'm actually immunocompromising you. I am opening up your first line of defense in your immune system, and I'm going to bring a lot of potential pathogens from the outside world into your body. And one of the procedures that we typically do for general surgery or more major surgical procedures is there is pre-op things that the patient has to do. There's a pre-op diet. There's also antibiotics that you have to take prior to the surgery, because and again, back to what we're talking about here, every rule makes sense. Another rule is nothing per orum, or NPO, nothing by mouth, just sips of water, right? For at least the day prior. I believe it's 10 to 12 hours, and that it runs the same rules for fasting. So if the patient has an 8 a.m. Surgery time, they have to have an early dinner the night before and nothing by mouth by 7 8 a.m. the night before. I mean 8 p.m. the night before. Now, an example of why that rule is there is because the gas that we use to put you under can it can make you vomit, and if you vomit before, during, or after your procedure, because we gave you anesthesia, your epiglottis might relax. And if you vomit, some of that vomitus might end up in your lungs. And if it does, that's called aspirational pneumonia. Your lungs are relatively clear of most bacteria, but if you throw all the bacteria that was in your food, plus the acid from your stomach, that's bad news. So you could see how that rule has to be strict. And how many patients that I had in the past, oh, I had a little bit of breakfast, and then it ruined it. Then we can't go to surgery. Then we have to reschedule. And not just the surgeon is inconvenienced. Think about the entire team. You have your anesthesiologist, you have your surgical technician, the one who prepares the room, you have your circulating nurse, you also have the scrub nurse. There's so many people who just got messed up. And of course, there's a reason why we scheduled the procedure on that particular day. So you could see how all the protocols kind of layer into each other, and how following all the rules and regulations to a T. Like, for example, it's only week 1, and we have people not following the rules in the laboratories. Not everyone is wearing their lab coat. Not everyone's gloving up. Not everyone's keeps their mask on for the duration. That's a problem, because what happens to our aseptic technique? If we look at the word asepsis, it means no or not, sepsis, which is bacteria that goes within our system that is not beneficial to us, that is pathogenic. So let's look at what do we typically do and how do we typically set up. And of course, we go to the top of our course shell. We go to our textbook here, and the textbook is the this one. So, and we're looking for chapter 44 or 45 or something like that. Look at our table of contents. And I'm looking for assisting with surgeries. And there are several departments that have surgery. Lab, no. Clinical practices, history, vital signs, general, reproductive, pediatrics, geriatrics. Here you go. Chapter 44, assisting with minor surgery. And then, of course, we start off with the case. And they use these stock photos, so don't get confused. Like, hey, that was the guy who had, remember? That's the same picture of the guy who had trouble sleeping, but actually it looked like major depressive disorder. It was that guy. So let's just pretend he's a new guy. Peter Smith, the 73-year-old retiree, Caucasian male with a history of mild depression. Oh, well, I guess it might be the same guy. Now he's at our clinic holding a bloody towel over his left forearm. Okay, so chief complaint is looks like some trauma to left forearm, and the forearm is called the volar, V-O-L-A-R, volar surface of his arm. So we take him to the treatment area, and then we look at, he cut himself with a large knife while he was trying to cut a pineapple. Vital signs, let's see if there's any vital signs here. No. You notice the blood is leaking through the towel, so you know it's a significant amount of blood. So we control the bleeding. And remember from our emergencies procedures, the way you control the bleeding is direct pressure. And of course, we PPE because this is blood. Universal precaution states that this man right here has every bloodborne disease in the world, and you yourself have every bloodborne disease in the world. So we assume that we're in a dangerous place. So we glove up, we mask up. Now we apply a large dressing. Now you'll hear these terms, dressing versus bandage. Dressing is the gauze or the material that we put directly on the wound. The bandage is the the cling. It's called cling. Is the wrapping that we put around it. Okay. So with patient, we determine that the patient needs sutures. How do we know that the patient needs sutures? Or the physician would assess it, but typically we suture up something that has wounds well beyond the dermis. And if you remember the emergencies section that we talked about, and we talked about the different types of wounds, he most likely has a laceration, not a laceration, has an incision wound because it was for a knife. But you never know, he could have held the knife like sideways and it could be a laceration. But either way, it's deep enough that it made him bleed, and it's also deep enough to warrant stitches or sutures. So we have to prepare him. So we have to clean the wound thoroughly. Okay. And he started swimming for exercise, and he's going to the Bahamas, and he wants to know if this will ruin his trip. No, should be fine, right? He just has to make sure that he changes the dressing regularly, right? And also takes the antibiotics that we gave him. Okay. So, well, I'm assuming that because they didn't say how deep the cut and also how long the cut, and on the volar surface of your arm, there's not a lot of major arteries there, unless he cut himself close to the wrist. But uh, it shouldn't impede his trip, is what I'm saying. So let's think of him, of course, and while we go through this chapter. Okay. So what is your particular role when you're doing things? Because your particular role is to, of course, always assist the surgeon. It goes, and there is pre, peri, and post-surgical tasks. And some of them are administrative tasks. And the discussion, one of the pre-surgical administrative tasks is the pre-admission testing paperwork. Okay, so you're going to be doing research on why that's important, but I'm just going to give you a little hint. You can't just cut somebody open. We have to make sure that they're okay medically before we do any surgical procedure. Okay, and also you have to for other administrative tasks, you have to make sure that, remember I mentioned all the team members. Well, in major surgery and minor surgery, you have to make sure that all the team members are available, okay? And all the equipment is available. Remember I mentioned the surgical technician, okay? Make sure all the medication is available. Now, the antibiotics, we know our patient will be taking antibiotics pre-surgical, and then the patient will continue antibiotics at least for a week in the post-surgical phase. Another drug that you should also be ready and make sure that we have a supply of is anesthesia. Now, anesthesia is a medication. If we look at the word anesthesia, let's do a little, oops. Where's my, well, I'm just going to break down here. I'm taking too much time. Anesthesia, if you recall the medical terminology, ia means state or condition, an means no or not, esthesi means to feel. So we want medication to make sure that the patient doesn't feel me cutting into them or me sewing them up, because it's quite painful actually, right? We also want to make sure pre-surgically that the patient is not allergic to anesthesia. One of the major concerns that we have pre-surgically is anaphylaxis. And if you call anaphylactic shock or anaphylaxis is an extreme allergy or an allergic reaction to something. And so we want to pre-test our patient prior to doing things to make sure that they're not allergic, because once we give the full dose, that's a problem. Irrigation and cleaning of the wound. Make sure we have enough normal saline. And remember, we talked about irrigation of the eye and things like that. It's all the same thing. Wound debridement. Do you have a sterile brush ready to remove the foreign bodies? And that's what debridement is. Removal of foreign body, removal of also necrotic or dead tissue. Okay. Do you have all the instruments? That's another thing that is part of your responsibility. What instruments do I have to do the surgery? And one of the instruments you could have for cryosurgery, you have these little chemical sticks that on the ends of it, be careful. It's like it looks like a match, but the tips are blue. Do not touch the tips with your hands. I accidentally rubbed my finger on one of the tips, and it's super, super chemically cold, and it will freeze dry your skin, and it's very, very painful. And if you're doing cryosurgery, you have to prepare for that. Laser surgery uses light, so make sure that machine is clean. Make sure that machine is ready. The electrocautery machine, make sure, and cauterization is, we utilize electricity and heat to burn away. Let me show you the electrocautery machine. See, it's like this little box, and it even also has, here you go, I can make it bigger. It's the box, and it tells you like how much energy you use, and then it has this probe thing that connects into the box, and then there's a foot pedal. So all you'll be, if you're in a surgical service, they'll train you how to do all that, and again, they'll also train you how to clean it and disinfect it. Here's the electrocautery. If you look at that, see, it's like a pen, and it plugs into the machine. And when you press like a yellow or red button, it means it's on, and it's going to flush electricity through here. And we can cut and burn things with that edge. And it's better than a scalpel, because if a scalpel, it could become not sterile, right? So a cautery gun or a cautery pen, it can't go not, it can't, it'll be difficult for it to get dirty, because it, on the tip of that, it's electricity, and the electricity superheats that end. So it's like kind of just like laser surgery as well. Like, it's a cleaner way to do things for certain types of minor surgery. So there are some examples of minor surgery. Repair of the wound, just like our case of Mr. Smith, right? Cleaning wounds, debriding wounds, removal of small growths like maybe small little polyps or skin tags, foreign body, right? Removal of a nail, that's not fun. I've had that happen to me once or twice. Drainage of an abscess. And remember, abscess is this big bag of pus. We can't leave pus inside our system, or things will get worse, or you could get sepsis, because what's in pus? Dead skin cells and dead bacteria and necrotic tissue. That's the big thing in abscess. That's the big thing with foreign body. That's why we have to debride. Debridement removes all the necrotic tissue. And we need a sterile brush for that, betadine, and of course, normal saline. If you're doing a biopsy, right? Of course, like fine needle or we're taking a piece of an actual growth. And of course, cryosurgery, laser surgery, and electrocauterization. Okay. So again, here they go through all the examples that I was telling you about. One of those things that we can also remove is a mole. A mole, also known as a nevus, is actually a benign cancer. So they may grow back, but we can remove them. We can remove them with lasers. We can remove them with cold cryosurgery, and we can remove them with an electrocautery machine. I wanted to show you the cryo, so you know what it looks like before you go out into the world. Now, this is another form of cryo where they have this like gun that's filled with liquid nitrogen, right? That they use that for more extreme, but there's also one that looks like a matchstick, and you could see what it does here. Like, let's say there's these growths or these moles or these skin tags, right? We take the spray and we freeze dry it, and then it just peels right off. And we could do the same thing with those cryo sticks. Okay, and that's cryosurgery. Did that. Now, effective wound healing. Okay, this is kind of important for us to understand, and why we have to follow all our steps and all our rules. And we have to have also pre-admission testing. Another little hint for your for what is pre-admission testing. You got to know the history of the patient, because if they have any hypertension or poor circulation, and if they're older, greater than I forgot the age, I think it was 62 when I was in training. Around the age of 61 or 62, the mortality of a patient that going into surgery drops dramatically. Raises dramatically. So the older you get, the higher risk you are to dying on the surgical table. And we don't want that, of course. No one wants you going in the hospital. So it's one of those things that you have to that the surgeon has to weigh in on. How many times that myself and the surgeon would be debating on whether we should proceed with surgery. Here's a classic example. I had she was like what, 69, 68-year-old female grandmother of 4, and she was diagnosed with pancreatic head carcinoma. Pancreatic head carcinoma, you could do something called a Whipple's procedure, which removes your pancreas, part of your stomach, part of your duodenum. It is severe, and it is almost 6 months to a year recovery time for a 68-year-old woman. And the prognosis for pancreatic head carcinoma is that they'll die in 3 months. So do you think that's beneficial for somebody? Well, I told my patient, enjoy your 4 children, go enjoy your grandchildren. I told her the prognosis, you have these choices, and she chose going to Disneyland instead of massive chemo and surgery. And fast forward, she came back to my ER because her symptoms started getting worse. A couple of months later, around 2.5 months later, I was expecting her to be like, oh, I should have had the surgery. But right before she passed, she said, thank you. You don't get too many thank yous in the medical world. But every time I think about deciding or helping decide what's good for our patient, but ultimately the patient has to decide. The surgeon and I and the oncologist gave her options and gave her the pros and cons of all the options, and she took the option of no treatment or nominal treatment, so she can at least spend time with her grandchildren. But if the patient's younger and the survivability is better, of course we will promote the surgery. Diabetes. Patients with diabetes have very, very poor wound healing. Think double of recovery time. So that's another thing to consider. Poor nutrition. Are they a smoker? Are they a drinker? Are they obese? That's a problem. Um, High levels of stress. What, and remember I stated that in what do you call that? In when you're looking at your history, you always have to mention what kind of job your patient has, because what kind of job your patient have gives you an insight on what kind of lifestyle they have. And if they're like, let's say for example, someone's like a CEO of a Fortune 500 company with 5,000 employees, that person's stress level is going to be high. Therefore, cortisol levels will be high. Healing time will be what? Low. They'll have a very low, I mean, not low, but poor healing time. And also they will have a large propensity towards infection. Okay. And that's also same thing is related to a weakened immune system. If you're diabetic, obese, chronic hypertension, and I mentioned obesity here. Now, obesity has this other little thing that we're worried about, especially in general surgery where we use gas to put you under for your anesthetic. Um, uh, the gas, particularly halothane, loves to is very fat soluble. So the bigger you are, the more obese you are, the more fat you have. The gas tends to hide in that fat, and the potential for overdosing my patient is very, very high. So that's why when the patient's obese, we try to tell them to get the weight down a little bit before we do the procedure. And of course, smoking makes sense because you'll have poor circulation and you'll have poor respiratory or breathing capabilities. There are many general surgical procedures that we do where we have to intubate and put the patient on a mechanical ventilator. And if they're smoking, their lungs will not be that efficient, and there's potential for trouble. So this bulleted list right here, these are a lot of the things that they have to consider in the patient's history and how they would be healing post-operatively. Because remember, it's not just the surgery. Many surgeons, not many, but there's some surgeons who believe like, oh, my patient did great. Well, we don't know yet, because even though the surgery was a success, we have to truly measure the success post-operatively. But many surgeons like, she's good, he's good. But since I'm in the Department of Internal Medicine, I deal with the aftermath. I deal with the 6 months to a year of rehab that you have to go through after you had your surgery. Okay. Proliferative phase. This is the healing. You could review that in your anatomy physiology. Remember, there's phases to healing, and wound approximation is really important. Remember the difference between a laceration and an incision. An incision has a nice clean wound, so the two ends of the wound will be approximated, and they'll heal better, and you'll have less of a scarring. But if it's a jagged uh, um, if it's a jagged tissue, like a laceration, it'll be hard to heal. Another thing about healing is also if the patient is of African American descent, they also have a potential for something called a keloid. Uh, Again, it's an abnormal reaction to the healing process, and it's just like, in a way, localized anaphylaxis. It's like an extreme reaction, and then it forms. Why am I just explaining it? Let me just show you. It doesn't form a very nice. See, like the wound approximation here is jagged or rough. It forms an overgrowth of scar tissue, and it looks like that. Okay, because typically you'd have just a scar, right? And it would be a little bit more like this, pretty straightforward. But a keloid, it gets exaggerated. Okay, let me move. I really should move this thing. How can I move this thing out of my way? Just go like that. Okay. Now, what's next? We went to laser, right? Electrocautery, discuss that. Okay, the instruments. Let's look at some of these instruments and let's look at them in a little bit better detail. And when you go into lab, and like I said, again, you guys already paid for it. So please take advantage of your laboratory because it's important. You have your sharps, the things you cut with. Now, if you notice some scissors, and this thing is called the fulcrum, and you typically put, well, I'm not going to go into greater detail because we're going to show you all of this in lab. One side would be sharp, the other side would be blunt, right? And that's a sharp blunt and a sharp sharp. And sometimes scissors are blunt because they're used not really to cut, but to kind of like open up tissue. And then you have curved, so it can sneak under things. You also have curettes, okay? And it's essentially a spoon that has no middle, and the edges are very, very sharp. We use this for dilatation and curettage in obstetric procedures. Here's your Lister scissors, and they're bandage scissors. And you know they're bandage scissors because it's a sharp blunt. You have the sharp side here, and then you have the blunt side that sneaks under the bandage. And remember the difference between bandage versus dressing. This is a Spencer, also known as suture scissors. And this is how we open up sutures. See this little hook? It hooks right underneath the sutures, and you could cut that. Of course, you have scalpel, you have the blade handle, and the blades are numbered and classified. And you will also notice on the handle, there will be a number that has to match with it. There are some with the retractable device, but these are the typical ones you use right here. So these are like your typical basic surgical. Oh, by the way, all of these have actual names, right? And we'll discuss those names in laboratory. And you can see there's different kinds of scalpels and there are different numbers, okay? So make sure, oh, that's one of my greatest pet peeves, that when the surgical tech or the medical assistant doesn't set up my material right because I don't have time to go to Central Supply, get the proper material, and then come back, okay? And also be very aware of scissors and sharps. When you organize them together and organize them and be wary that they're sharp and they can easily cut you. Of course, forceps are things that we use to grasp and hold, you know, kind of like big tweezers. But a hemostat is very, very different. I think there's pictures. There you go. Let's just go right into the pictures. So you have these forceps, and you'll see like you have Adson, Babcock, Semkin, Cushing bayonet. Well, all of them are very different, and in lab we'll show you that all of these thumb forceps, they're all smooth. Meaning to say is the tips of these, they don't have little teeth, okay? So Adson, Cushing, Semkins, right? They don't have any teeth on the end. So their function is to pick up delicate things or small things. But if you have a tissue forceps, that's the one, they have little teeth on the end, like that. Let's look at it a little closer. There you go. It's got little teeth or serrations on the end, and those are tissue forceps. So if the surgeon asks tissue forceps, please, you make sure you get one that has little teeth on it. And also it goes, if they ask for a Semkin, a Cushing, or an Adson, or a thumb forceps, you get something that has no teeth that will pick up something, something more delicate and smaller. Now, what are hemostats? Hemostats, just like your scissors, can be curved so we can sneak under things. And the thing about hemostats is let's look at the word hemo, blood. Stat means stand still or to stay in one place. So you have your Kelly, you have your Cryle, Rochester, Ochsner, right? All of them have this locking device here, okay? And what does that do is when you take a hemostat and you clamp it on to an artery or a vein, and then you lock it in place, because it won't destroy the artery or vein, but it will lock it closed so you can do the surgery without blood going everywhere. Here are some holding forceps, and part of that family, you have your Backhouse and you have your Jones. Those are towel forceps. They hold the towel, you know, the surgical towel that we have for the surgical field. Let me show you how that works. Where's a good picture? This one's good enough. Let's look at, if you look at this picture right here, all right, how about this picture? You see, we're gonna do some surgery, and you see how we put drapes all around. Well, some of these are disposable, and then some of these are not disposable. So when we do the draping, right? Let me get this. Oh, good. Get this picture here. When we do the draping, as you see here, do you see how all these towels here, they could easily fall off and maybe fall off the table? Well, we take those towel clamps and clamp them in here to the rest of this surgical blanket so that things don't move around. And that's their function, these. But be careful, they're really sharp on the end here. Now, holding forceps, we hold like gauze, bits and pieces of tissue. And again, just like the tissue forceps has little teeth on it, but they're much, much longer. Judd Alice, what's the other one? This is used for sponges. This is the Forster. And they have this little circle, and there's little serrations and little teeth here. So make sure you know that the difference between these holding forceps, and you can see they're much, much longer than tissue forceps. Tissue forceps is like 3-4 inches tops. This thing could be like 8 inches long plus. Let's now look at retractors. Sen Miller, very common. Now, what's a retractor? You can see a handle. We have to open up the wound area so that the surgeon can go in and do their business. And one way we do that is with retractors. We hold both sides, and oh, that's a difficult job. I hated doing retraction. Let's see if they can have a picture of that. Okay, see these? These are nice clampy ones, right? This is a retractor. It's retracting or pushing all the skin and all the stuff out of the way. Now, in minor surgeries, right, this is a major surgery, we'd set up all of these things and all of these clamps and all of this stuff right here. But in minor surgery, if you look at this, it'll be your job to hold it. You hold it at these ends, right? And then this one, you hold at this end. The Sen Miller, you should typically hold it from like the middle to the back, and you could see how on the ends it has a little stop so that you won't lose grip. Okay. Murphy, you put your finger in this little hole here, and then you could retract that way. Now these are dilators. These are for debridement and curettage, or anything that we have to do in the through the vaginal canal and the uterus, especially the cervical part of the uterus. So this goes inside the cervix, and you bend it, and it'll open up the cervix just enough so we can see what we're doing, and uh, and do whatever procedure that needs to be done in the interior of the uterus. Probe. There are things where, you know, if you want to point at something or to poke through something, you use these. And this is a Sims uterine sound. We use this also for pelvimetry to do measurements. Each one of these little ticks here, you see here, it's in centimeters. So we could see, pelvic measurements when we're doing internal examination and an internal exam on our patient for obstetrics. Here are suture materials, and do know and understand that, of course, they're sterile, and I'm going to show you how to play with these when in lab, right? If you really take a good look at all of these sutures, all of these needles, they cut. So be careful. And again, we could use also needle holders. And how can you tell a needle holder from a hemostat? Well, a needle holder, the fulcrum, or where the little parts of the needle holder meet, this end is the little mouth here is much, much smaller. And if you look on the inside, there's this little groove here where the needle can fit. And that's how you know you have a needle holder. Just like anything, we have different types of sutures. Some of them are gut, meaning they'll dissolve in the body. Some of them are artificial. So we'll be looking at that in lab, and you see a lot of information. The gauge and the length. Gauge is how thick the suture is. What kind of material, right? Nylon, that means it is synthetic, means I have to remove them in 7 to 9 days. And of course, this is very important, expiration dates and lot numbers as well. Because let's say, for example, 1 or 2 patients, right, using that same batch, right, not the same suture, but the same batch, got sick or had an infection. We're going to look at the lot numbers to see if maybe we got a bad batch. Happens every once in a while. Okay, this is a Mayo tray, and I'll show you that in lab. Do you see how neat everything is? How all the thumb forceps are in one place, all the gauze is one place, all the sharps are in one place, and all the hemostats are in one place. So it's easy to see and easy to understand. You'll also notice that there is at least a 1-inch border around uh, um, my preparation tray. The Mayo tray also is made out of metal and can be sterilized. And they call them, the Mayo tray is interesting because it has the top portion, instead of me just talking about it. Let's look at a typical Mayo tray. If you look at this, dang, they're cheap. Might buy me, well, I have more than enough. Here's the one that we have in our lab. The top part is removable like this, right? And there's usually wheels around and only wheels on one side. So when you move it, make sure there's nothing on this. You tip it and then you roll it around. I'll show you in class. But the top part can be also removed and then sterilized as well. Okay, all right. Remember that 1-inch border. And they also could come in surgical packs. You might be even responsible to create the pack. And I'll show you what's that all about as well. And then you could have these incision and draining kits, or I&D kit, laceration kit, also known as a cut down kit, right? Suture removal, right? Kit. You know, we have all these little prepared kits in the hospital so that we don't have to think too much. But again, you could be the person who is responsible for that. We mentioned asepsis. We already mentioned PPE. You always have to glove up. We're going to be talking about in the laboratory the different kinds of scrubs, and you watch the videos and you watch the notes that I have that I already put in. One of your responsibilities in preoperatively is to maintain and to create and maintain the sterile field. And because once someone touches the field, that means, or crosses the field, then we have a problem, because we're trying to keep the area around the opening of the surgical incision as clean as possible. And remember my statement, as clean as possible. So once you create your sterile field, make sure you're gloved up, make sure you're already masked up, and you don't need anything else. And you just have to be careful and be really aware of where your hands are. I can't tell you like half a dozen times in my training that I bumped into the surgeon, or I bumped into the table, or I bumped into the patient, and then I was asked to step out, and then I have to go through the whole aseptic procedure of washing my hands, gloving up, and remasking. Okay. Rules for sterile technique. Let's go over that. Okay. Again, you don't touch any sterile areas once you have defined what they are, right? Anything outside of that sterile area of where you had your sterile drapes and your sterile towels, it's considered dirty, even though it's relatively clean, but it's considered non-sterile and dirty. Unused and open up supplies must be discarded, even though they're on the Mayo Tray. There's only one set for a patient, and the place you discard it, of course, sharps go into sharps and biohazard goes into biohazard. Packages must be wrapped and sealed in a way they can be opened without contamination. Maybe you recall your MED 140 training where you open up things like a banana, right? And again, gloved hands. 1 inch margin covering the sterile supplies. We already talked about that. If a package becomes wet, or anything that becomes wet that's outside of the sterile field. Now, if it becomes wet from the patient's own blood or own fluid, that's one thing. But let's say, for example, a drop of sweat, either yours or the surgeon's, gets into that package, even though the package is sterile and still in its package, you can't use it anymore. If anything that drops on the floor, you can't use it anymore. Do not pick it up, but account for it, because at the end, you have to account for every single piece of equipment that was used, because you don't want anything left inside the patient. Keep your hands between your shoulders and your waist. It kind of looks like praying. We'll show you in lab. You ball your hands in a fist and cover the other hand, and you keep it like not on your chest, but right in front of you, so you know at any given time where your hands are. And when you're walking on people, right, make sure you announce where you're going and look where you're going before you move. And if you do move, you're always moving back to back in a surgical setting. And we'll show you exactly why when we're in lab. And you probably already know, because you already had MED 140. We're also going to be practicing surgical scrub, which is the scrub that goes all the way up to your elbows. So it's not the scrub that you do your alphabet and you do it real fast, not even in a minute. This scrub takes 10 to 15 minutes, and we'll go over and requires a sterile brush with betadine. And I'll show you how to do that in lab. Okay. Preoperative, we talked about that, setting stuff up. One of the things that you are setting solution. You see that even in this drawing, there's a 1-inch border, or at least 1 inch. Preparing the room, preparing the skin, okay? Now, when we clean, when we get, let's say we're gonna do some surgery or some major or minor surgery on, not major, it's called general surgery or minor surgery on our patient here. Just like phlebotomy, when you clean the area, right, and then you have to do your betadine, which is an iodine-based solution, you always start at the center and then go in concentric circles, but you're not covering the same area twice. So you're progressively going outward. And so you're not going like this or up and down. It always starts in the center and then in concentric circles, circle, circle, and progressively wider, okay? And that's the difference between surgery and other things, that we're gonna go that extra step to make sure we kind of like sanitize the patient's skin area. And it's probably not the best way to say it, but you know what I'm saying, that it's not just putting alcohol. We have to also utilize the iodine based solution, also known as betadine, and also be very liberal with it. When I first started training, when I was an MA, I felt like I was using too much. You got to really pour it on there. Removing hair, shave if we need to, right? And of course, that iodine based is an antiseptic. It's providine iodine, also known as betadine. You could also use chlorhexidine, that's hyboclens, and bencolonium chloride, Zephyran. I haven't used Zephyran too much, but betadine hyboclens, I used to use it all the time for minor surgeries. Local anesthesia. All right, please don't do this. Jeez, I don't know why this is in your book, right? You prep it. You could see the danger in this, how nutty this is, right? Or you have the material ready, and just like in your pharmacology, check that label against the original doctor's orders at least 4 times. Trust me, because how many times on my 4th time I found that the dose was wrong or something was a little off. Okay. And the injection most likely we'll use is epinephrine, right? And it will do 2 things. It will not only anesthetize my patient in that area, it will also constrict the blood vessels so there won't be too much bleeding. You could also be assigned as the floater. You are not sterile. You're the person who's going to step in and out of the room, okay? And you could do either monitoring or recording, or you could be the person supplying the specimen, bringing the specimen to pathology. And that's what the floater does. And sometimes sometimes pathology has a question in the middle of the surgery, and the floater is the one who, answers the phone and relays the message to the surgeon and to the other nurses and to the surgical technician in the room. And that's what a floater does. But the one thing you have to know about floating is you are not sterile. So don't bump into anybody or there'll be hell to pay. I remember my first time as a floater, I bumped into a nurse and I got the business. I got chewed out for that big time. I'll show you in laboratory how to handle instruments and how to properly put them in my hand, especially things like scalpels, okay, or sharps, okay. And also one of the things we'll be practicing in laboratory is how fast can you identify the instrument required, because surgeons have a pet peeve about that. So if I ask for a Kelly, I want that in my hand, like boom, grabbed it, Kelly, in my hand. And you have to kind of slap it into the hand so that the surgeon knows that you are definitely handing it over to me. And heaven forbid if you drop it. Again, if you drop it, even if it falls a little bit outside the sterile field, like on the edge of the operating table, it is considered dirty, it's considered contaminated and you can't use it. Dressing and bandaging, we already talked about that, right? Postoperative instructions and wound care, dietary. This is big thing, proper wound care instruction. You don't just give them the pamphlet. You make sure that they understand what they have to do and when they have to do it, because postoperative wound infection is very, very common. Okay? How to deal with the pain, okay? Hot and cold packs, right? And they'll typically have a follow-up appointment, especially if it's for removal of sutures within 7 to 10 days. So make sure they make that appointment, all right? Make sure they understand, they know what bad wound healing looks like. And that if they have any fever or any pus or any discoloration of the wound area, they must go to either the emergency room or someplace like Patients First. And of course, you're responsible for cleaning up the room, and the room should be better than it was prior to the surgery. So look at these things, how to create a sterile field, right? Remember the 1-inch borders? Performing surgical scrub, read over that, and or watch, there's a whole ton of YouTube videos on it. How to take off your gloves, how to put them on, and we'll be doing in laboratory how to put on surgical in these packets. Very, very different than donning on those latex gloves that are in a box. Okay. And here's some extra notes here on how to what is your responsibilities if you're a floater. Okay. All right. Other than that, that's all I have. What is due this week is, of course, let's look at what's due this week. And I purposefully did not put your midterm like last week because I know you guys have other classes. So this week, I'll put up your midterm. Ooh, did I do the, I skipped ahead. I was supposed to do pediatrics. Oh, well, how's this? Do topic 7 stuff because I'm ahead of myself. We were supposed to do pediatrics and geriatric stuff. So, yeah, oopsies. Sorry, my bad. I did the surgical stuff. So do week 7 stuff, and then next week we'll do week 6 stuff, pediatrics and geriatrics. So again, and I'll put that in announcements. My boo-boo. But hey, you got through surgery now. So do a topic 7 items for this week, topic 6. And that would be a discussion and an email with the quiz answers. And of course, I'll be giving a take-home midterm. And once you see that in announcements, yeah, I'll give you like a week or 2. It's no big rush. It's more of a, like a larger homework assignment. All right, let me put that in the announcements right now. Is actually week 7. Okay, so if anyone has any questions, nothing, then that's it for the week. And again, get me your schedules for lab so I can confirm when you guys are coming in. Okay, any questions?
No questions.
Good. All righty. I'll see you when I